I'm Dr. Maureen Nash, and I was asked to come and talk about dementia and delirium and how they affect your brain. And as part of that, I'm really going to focus on two particular types of brain functioning: executive functioning and what we call anosognosia, and how that all relates to decision making. I'm hopeful that at the end of this presentation, you will have the basics of what you need to know when you're talking to people about dementia and delirium, people who have dementia and delirium, so that you can help decide what it is that they're able to do and what they're not able to do. So just as a little bit of background, I'm going to let you in on some secrets about physicians. So physicians are trained to diagnose and treat illness, and that's really what we do every day. And when I, as a physician, am working with a patient to make a decision, I really am always looking at very concrete, specific things. I'm talking to one person about one medication or procedure, and usually about one particular illness. And so it's very focused, and it's not general. And when the courts are looking at things like guardianship, what they actually are considering are, what are generalizations that people have? And what about their general abilities? And so there's a little bit of a mismatch, and not all physicians understand this difference, and not all legal professionals understand the difference. And then finally, in a physician's office, they can do some very common screening tests, but the key to these tests is knowing what they're telling you. And different physicians have different training and backgrounds and experiences. So some of the most common tests are a mini mental state exam, a St. Louis University mental state exam. Those are really probably the two most common. And they really tell us a little bit about a person's functioning, and they're screening tests, but you can't really solely use that as a diagnosis. Less commonly, but still you may very well hear about a MoCA, a Montreal Cognitive Assessment, an Allen Cognitive Level, which is an occupational therapy functional test. And then finally, there's some less common ones: the clock drawing, a mini-cog, and a Trails A and B. And the key question that you're going to have whenever you talk to somebody about one of these tests is, how'd the person do on the test, and what does that mean? Because that's the key thing. What does the score tell you about this particular person? That's what you need to know. So the sort of grandfather of them all is the mini mental state exam, scored from 0 to 30. Almost everybody is trained to do it, but there are some real challenges. The most difficult part of the whole test is to give people a 3-step command and ask them to do it. But not everybody actually gets that. So sometimes people, instead of giving a person 3 directions to do 3 different things, they give a person directions to do one thing, and then they wait, and then directions to do one thing, and then they wait, and then directions to do one thing, and then they wait. And that is actually an entirely different task that is much easier on the brain. That's actually giving people 3 one-step commands. And so those are sort of some of the tricky things when you're interpreting tests. You really need people who understand how to do it when they're doing it. And one of the other main problems with the mini mental state exam is that it has no testing that tells you about a person's ability to make decisions. There's no what we call executive functioning testing. And that's the little part of your brain that helps you make decisions, weigh the pros and cons, so that you can sort of direct things in your own life. And then finally, it is very sensitive to education and intelligence. And so if a doctor scores, say, 25 on that test, that doctor is probably very, very impaired. A teacher scores 25 on that test, they're probably impaired. But if somebody has a 5th grade education, or if somebody is illiterate and they score a 25, well, that means something really, really different. They're actually probably doing pretty well. This is just a picture of a St. Louis University mental status exam. It's a little bit more challenging, has a little bit of testing of your executive functioning, though still not very much. So again, you're going to want to know what test was used, what was the score, and what does the doctor think that that means. Those are always the questions you want. There's a whole different kind of tests, and occupational therapists really focus on that. And that's the functional tests, where you actually get somebody to do something, you watch them do it, you watch their problem solving. And in particular, a very commonly used test by occupational therapists is the Allen Cognitive Level, or ACL. And the key thing to know about the ACL is that the score correlates to lots of things. It correlates to how much assistance a person needs in their day-to-day life. It correlates to how much, what level of care is the right one for them. And really, it tests what we call functional cognition. There are a lot of other functional cognition tests out there, and occupational therapists tend to be the experts in that area. This just happens to be one that is commonly used. And the great thing about an occupational therapist and their testing, they are actually trained to look at where a person has strengths, where they have weaknesses, and what can we do to modify the environment and support a person so they can be as functional as possible. So that particular kind of testing information is much more useful to a court visitor and to a judge than the paper and pencil tests. One of the key things to always consider when you're working with especially older adults, but really anyone, is the thing that is affecting their brain and their ability to make decisions. Is that a temporary thing? Is that a permanent thing? And now you as a court visitor wouldn't be making that determination, but that's the question you want to ask the people who are caring for the person. And just as a thing to keep in mind, there are three things that really affect medical decision-making in a major way, especially in older adults. One is whether somebody is dehydrated. Dehydration, our brains are very sensitive to hydration status, and so it's very important. The hydrated brain is a happy brain, that's what I always like to say. The other thing that is very common, especially in older adults, is medications. Many medications can affect how your brain is working. Some of those medicines have a short half-life and a short impact. Some of those medicines have a long half-life and a long impact. And then finally, an acute illness, especially an infection, can definitely throw any older adult off. And so you don't want to be making decisions about a person's ability to make decisions over the long haul based on just a little picture of how they're doing right today if what is affecting them is solely one of these temporary conditions. I'm not really going to spend much time talking about all these illnesses, but I want you to be aware of some of the medical diagnoses that are common in older adults that can really affect and impact brain functioning and decision making. And these are the sort of things you want to keep in mind when you're talking to people and talking to the people who care about people. So dementia obviously impacts things, and we're going to talk about that more. You've probably heard a little bit about depression already, or you will in another video. Delirium is an acute confusional state. I'm going to touch on that briefly. And then a CVA or a stroke. So a CVA is doctor talk for stroke. Heart failure, congestive heart failure. Heart failure really impacts how much blood is flowing around in your body, and that blood is carrying oxygen and glucose, and that's why that particular illness can really have a negative impact on your cognition. COPD, or chronic lung disease, kind of the smoker's disease, that also really can affect oxygen and therefore can really affect how you're functioning and how well your brain is doing. And if you have one of these medical conditions, a lot of times those impairments are not temporary. You know, they may get a little bit worse or a little bit better day to day, but a lot of the impairments that people suffer from go throughout the time that they have the illness. And so it's not something you can say, oh, well, they just have problems because of this, so it doesn't matter. Well, it certainly matters to that person and their ability to make good decisions. Diabetes is another common illness in older adults, and It really has to do with your body processing inflammation, processing blood sugar, and our brains are very, very sensitive to blood sugar. And so people who have diabetes have significant changes in their cognitive ability, in their brain's ability to take in information and process it. And so that's why it's really important to know about that. The other reason diabetes is important to know about is because some of the medicines to treat diabetes can kill you if you take them wrongly. And then finally, chronic renal failure, alcohol, drugs, there are many, many other things. But I just wanted to, again, highlight some of them so that when you're looking or talking about a person and the challenges they face, those are the kinds of things that you need to know about. I'm going to spend the bulk of my talk really on dementia. And dementia comes in many flavors. Sometimes people get very confused and they say, oh, if I get dementia, it's okay as long as I don't have Alzheimer's. When, in fact, Alzheimer's is by far the most common kind of dementia. Alzheimer's disease is probably between 60 and 70% of people who have dementia either solely have dementia, Alzheimer's disease, or they have Alzheimer's plus something else. The next two kinds of dementia are also relatively common, and you're likely to run into them when you work with people who are older and have brain problems. So Lewy body disease or Lewy body dementia, and then Parkinson's disease dementia. Those are they're sort of cousin illnesses, and they both have the same reason that your brain isn't working well in both diseases, but where the brain is affected affects what symptoms you have. So not everybody who has Parkinson's disease develops Parkinson's disease dementia, but those who do definitely have cognitive impairment and trouble making decisions because of that. As with everything, it increases over time. So it might be small problems at the beginning of the illness and then really severe problems later on in the illness. The other really common kind of dementia that you might hear about is frontotemporal lobe dementia or frontotemporal dementia. And that's a series of several different kinds of dementia that affect two particular areas of the brain, the frontal lobe, the temporal lobe. So I'm going to touch on that as well, just a little bit. And then finally, anything that affects your brain if it affects enough of your brain or impacts sort of the wrong area, that can cause a dementia. So the next topic we're going to talk about is delirium. And sort of the shorthand we use to think about delirium is an acute confusional state, sort of whatever that means, right? But the key symptom, the central deficit in people who have delirium is their attention is impaired, their ability to attend or focus on something. And if you can't focus or attend, sort of like little kids with ADHD, if you can't attend, then you can't form new memories, you can't process things, you can't keep a whole bunch of things in mind to make a decision. So attention, it turns out, is extremely important. And delirium is thought of as a short-term situation, and it usually is. However, it can last for weeks or months, and in fact, depending on how you look at it, between 25 and 50% of people who develop a delirium end up with permanent cognitive deficits. One of the other challenges is that acute delirium and what we call dementia with behavior disturbance can be identical if I just take a snapshot of them. So if I just get a history of the last 24 hours of somebody and they're delirious, or if they have dementia with behavior disturbance, they can look totally the same. So one of the keys is history. History. That's, in medical school they teach us that. 85% of diagnosis is all about history from the person or their family or their caregivers. And one of the key things to keep in mind about delirium is that if it keeps going, it really probably should be thought of as permanent deficits. Although on a rare occasion, somebody's been very delirious for a short, say, 1 to 2 months, and then suddenly they totally clear up. But that is extremely unusual. So a delirium that is prolonged often transitions into permanent cognitive impairment or dementia. Just a word about a stroke. So strokes can happen anywhere in your brain, and there are different causes of different kinds of strokes. But the one that I want you to focus on is that if somebody has a stroke in the right parietal lobe, that part of their brain, or in the frontal lobe, they can develop really big problems in understanding. And so the ability to appreciate how deficits or how things affect you is called anosognosia. And so people who have deficits in awareness of their own deficits and awareness of how their deficits affect them have that symptom that we call anosognosia. And the reason I highlight it is because if somebody has anosognosia, they are going to have significant difficulty being able to make good decisions because their brain is telling them that they don't have a problem. If you don't think you have a problem, you're not going to want help with anything, even if you clearly need major assistance. So anosognosia, or impaired awareness of deficits and how they impact you, they're seen commonly in people who've had right parietal strokes. They're seen commonly in people who have frontal lobe damage, and they can even happen in some chronic mental illnesses. And that's one of the reasons why people might go off medications, for instance, because they don't know that the illness affects them. Medical issues that are common that sort of don't necessarily cause cognitive impairment but make somebody look like they're very impaired. The number one is hearing impairment. But visual impairment and lack of exercise can also actually affect a person enough that they look like they're very, very impaired. Hearing impairment in particular, just like with little children, if you don't know that they're hearing impaired, they can look like they're developmentally delayed or have major problems, but if you can fix their hearing problem, they can grow up and function normally. Similarly, older adults who have hearing impairment can actually be diagnosed and act like they have dementia until you fix it. And if it's an impairment that can be fixed, then often people don't have any cognitive impairment at all. So these are just sort of things to keep in mind when you're working with someone. And finally, as a court visitor, one of the major things you're looking at is a person's capacity to make decisions. That's the big thing that judges make. That's the judgment that judges have to rule on in a guardianship case. Does this person have the mental capacity? And that is an extremely complicated function, and it doesn't really correspond to anything in medical, in a medical illness or one little part of the brain. There's no sort of magic to figuring out whether somebody has the capacity to make good decisions. And that's why we need judges. And that's why judges need court visitors. So mental capacity really involves having lots of parts of your brain work well. One is memory, one is your ability to be logical and think things through. One is the ability to have flexibility and pay attention to different things, weight things differently, and do multiple tasks either simultaneously or right next to each other in a sequential way. It's also true that mental capacity can be affected, as I referred earlier, to illness and by illness and medication, and especially by stress, fatigue, and dehydration. A few words about consent. So consent is really what doctors focus on, because I really want to know if you as a patient, are you able to consent? And again, when I'm asking you a question, it's usually very straightforward about, you have this illness. I think this medicine is likely to help you. Here are the risks of this medicine. Here's how I think it's going to benefit you. And here are other alternatives that you could take to taking this medicine in order to treat your illness. And then you decide yes or no. And as a doctor, what I want to know is, did you really understand what I said to you? So, and that's what consent is about. But the concept of consent is something that you as a court visitor are also going to want to be familiar with. So the four specific areas as a physician that we look at for consent is, does the person understand the question that you're asking them? It's really important. If they don't understand the question, how can they answer it? Do they understand what you're telling them about the various choices, about the risks and the benefits that you just explained to them? Can they explain it back? Did they really understand it? Finally, the two really important things, can the person express a choice? You might have seen people like in the movies who have what they call locked-in syndrome. They're laying in bed and they can't talk and they can't move, but as near as we can tell, their brain is actually really working well. Well, that's great that their brain is working well in some ways, but they can't express a choice, so they can't actually give consent. And that's really a key point. Can the person express a choice, and then is that choice stable over time? If I ask you, would you, here are the risk, benefits, and alternatives to this medicine or this surgery, and you say yes today, and I have the same conversation with you tomorrow, and you say no, that's not so good. That indicates either that you can't make up your mind or that you really didn't understand in the first place. So that's kind of how doctors are trained. When you look specifically at people who have Alzheimer's disease, and we're looking at consent and capacity, there are certain things to keep in mind. So Alzheimer's disease in particular, the first part of the brain that it attacks is a person's ability to make a memory. So it's sort of wish-washy. People have trouble making a memory. It takes them much longer. But then ultimately, a person loses the ability to make a new memory. And this is particularly disabling. Just think about it. You go to buy a car. The car salesman gives you the contract, and it has 5 paragraphs in it. So you have to read through the whole thing and remember what you read up there before you get to the bottom. And somebody who has Alzheimer's can start to read it. They might even be able to read the words out loud, but by the time they get to the bottom, all they see is a line to sign their name. And they don't actually understand anymore or recall anymore that this was a contract for them to buy something and they're going to have to pay money. So it's very disabling when you can't form a new memory. And that's the central deficit in Alzheimer's disease. And again, that's the most common kind of dementia. So that's why I'm sort of stressing it in particular. When you talk to somebody who has Alzheimer's disease, who may very well not know that they're impaired, there's certain things to listen for. People who have Alzheimer's often speak very vaguely. So it goes from, oh, I'm going to write a letter, to, oh, I'm going to take this thing, which is a pen, and I'm going to make marks on the paper. And then, oh, I'm just going to use this and this to write a letter. So that sort of speech becomes more and more vague as the illness progresses. Another thing that you might hear in somebody who has Alzheimer's when they talk is that they make word substitution errors. And we all make word substitution errors from time to time. I may have already made one while I'm giving this presentation. But people who have Alzheimer's repeatedly do that, and that obviously can be very problematic for communication when people are using a word different from what they're intending to say. And then finally, one of the real tricky things about Alzheimer's disease, conversational speech is preserved late until the illness. And so people can actually have Alzheimer's for 15 years, and you go in to visit them, say it's your mom, you go in, you sit down, you talk to your mom, you say, hey mom, how are you? And your mom says, how's Jill, who's your daughter? And how's Joe, your son? Well, the reason your mom can ask about those things is because she's been asking about your 2 kids her whole, as long as your kids have been alive. So it's very overlearned, and so it doesn't actually indicate that your mom has the ability to remember that you have 2 kids. An example would be, say you had a dog, or you had a new child after somebody develops dementia. They're not going to be able to fit that newer addition into the family. And so they may ask about people, but they'll always leave that last one out. So don't be fooled. Just because a person can have a conversation that sounds totally normal does not actually mean the person can understand everything that was said, and it doesn't mean that they can actually make good decisions. And so that's very tricky. Lewy body dementia and Parkinson's disease dementia by extension, I'm just going to mention a couple things about that. One of the key things that is really troubling to the people who have it and to the people who care for them is that in a single day, a person can be hallucinating and very impaired in the morning. And then 3 or 4 hours later, they can remember that they were hallucinating, they can talk to you about it, they can recognize that those things really didn't happen, and they look and sound and are in a much better space, and they can make good decisions. And this wild variation happens throughout the illness. And when the person is really, really impaired, they often are unaware of it. And so that's the thing that makes Lewy body dementia in particular kind of troubling. One way sometimes people talk about it as having mini deliriums every day, so many troubles with your attention and that ability to attend off and on throughout the day, every day. And so overall, you may have the ability to give consent and make a good decision right now, but overall, there will be many times when you can't. And so that's, again, that's why we need judges to make the hard decisions about whether this person is in a spot where they can, make good decisions for themselves. And one of the things that is, you won't really find in a textbook about Lewy body, but it's this ability to be flexible in your thinking is particularly challenging. And so these are the kind of things that make it very hard to treatment plan. And when somebody does have a legal guardian or a healthcare power of attorney, it can be really hard to find a spot where this person makes sense, because they need one kind of place in the morning, and they need a different kind of place in the afternoon, and they need a third kind of place at night. And of course, nobody can live in 3 places all at once when you have this unpredictable episodes of cognitive impairment. So when you're interviewing somebody about capacity, when you're interviewing someone really about anything, frankly, you really need the person to summarize back to you in their own words what you just said. And an easy place for you to start would be, you introduce yourself, you tell them who you are, you explain what a court visitor is, then ask the person to tell you back. Can you explain to me what you think I'm here to do? Can you tell me in your own words? And if they can't, that is a real key indicator that this is a person whose brain isn't quite working well enough. Because if they can't even do that, then how can they make complex decisions, life and death decisions, either about surgery or where they're going to live or what's going to happen to them? So getting a person to summarize back to you what the question was, what you explained to them, and various parts of it is very key. And you also, when somebody applies for a guardianship, there's often something going on, and so there's a particular situation. And so it's a good idea to ask the person, why do you think, your brother or your daughter is applying for guardianship? What's going on? And if they can't give you accurate information that matches all the information you get from other people, that's a clue that there's a major problem with their brain. And one of the key things is not to say, did you understand what I just said? Because 100% of people who have Alzheimer's disease are going to say yes. Because as far as they know, they do understand what you just said. So you can't ask a question like that. You actually have to test it. Tell me what I just said, or what do you think I meant? Or help me out here. I want to make sure I was being clear. What do you think I said? So Now that we've kind of reviewed all of that background information, I'm going to talk a little bit about specifically what is dementia. I don't expect you to be a person diagnosing dementia as you go through your day-to-day life, but I want you to know what it means. Specifically, the old definition was it means you have a problem with your memory of one sort or another. So it could be a problem making memories, a problem retrieving memories, a problem of memories being constant or changing, plus another problem in a major area of your brain, and these problems are affecting your daily functioning. So that's sort of the old definition of dementia, and it's really based on a model of Alzheimer's disease. The newer definition is you just need impairment in two major areas. And the major areas that we look at are memory, they're aphasias, which is a fancy word for your ability to use and understand language and express yourself in language. Apraxia, which is sort of your ability to use tools and use things that you used to know. So an example of a problem with praxis would be losing the ability to use a key or losing the ability to drive, even though you've been doing it for many years. The longer you've been doing something, the more likely you are to be able to continue to do it. And if it's something new that you learned how to do, like say maybe use a computer, it's quite possible that those are the things that you would lose first. So apraxias, impairments in being able to use tools or objects. Anosognosia, I mentioned a little earlier, and that's what we call impairments in insight or awareness of your deficits and awareness that the deficits affect you. Mrs. Jones, how many children do you have? I don't know. Mrs. Jones, where do you live? I don't know. Mrs. Jones, are you married? I don't know. You ask Mrs. Jones 10 questions. She says, I don't know to every one of them. And then you say, Mrs. Jones, how is your memory? And she'll say, just fine. That is classic Alzheimer's. So Mrs. Jones is somebody who doesn't have insight into the fact that her memory is impaired and her brain is impaired. And then sort of finally, you'll notice all those other words started with A. Finally, executive functioning is always the big elephant in the room. Executive functioning is quite complicated. There's many different parts of it, but in sum, I think of it as, the little person in our brain who actually makes all of our executive decisions. It's the part of our brain that takes in information, processes it, looks at the environment, thinks about everything about our life and various things that are affecting us, thinks about the past and the future, and then makes a decision, and then implements the decision, and then considers, how is that working out? Do I need to, I decided to go to college. Oh, it turns out this is really not my cup of tea. So somebody says, then I need to change my decision because it turns out I made a bad decision, so I need to change course here. That's what executive functioning is. Again, I reviewed some of this. There's Alzheimer's disease, which often coexists with vascular dementia, but you can get one or the other separately. There's frontotemporal lobe dementia or frontal temporal dementia, Pick's disease, Parkinson's disease dementia, Lewy body dementia, and then there are hundreds of other far less common ones. Huntington's disease, for instance, you might have heard of ALS, Lou Gehrig's disease causes dementia, dementia due to alcohol, or what's been in the headlines a lot lately is head injuries and concussions. I realize this may be the fourth or fifth time I've said it, but Alzheimer's disease is the most common kind of dementia. And historically, there's sort of two sets of Alzheimer's. There's early onset Alzheimer's and older age onset. Early onset dementia can start in the 40s or 50s, but has to start before age 65 to meet criteria for early onset. Late onset Alzheimer's disease, under a microscope, the brains are going to look the same. But late onset Alzheimer's disease used to be called senility. And back when we didn't know very much, we thought everybody who got older became senile. And that's just not true. Lots of people who are older do not get senile, do not develop Alzheimer's disease. But that's a relatively new concept. It only came around in the 1970s after we got better at looking at brains under microscopes. When people have Alzheimer's disease, there are no cases of remission. We have no disease-modifying medications at this point. And in fact, we really have a very elementary, simple understanding of what's gone wrong, in fact. 100% of people with Alzheimer's, if they do not die of something else, will become incapacitated, will become incompetent, and will not be able to make decisions in their own best interest. And just to give you a little idea, you know, they always say you should put pictures in your talks, and it's always one of my weaknesses. But here's what we call a cartoon view of the brain. Your brain doesn't really look like this, but it kind of looks like this. On the one side is a normal brain, and on the other side is somebody who has Alzheimer's disease. And what you'll notice is the Alzheimer's disease is shrunk overall. That's what we call atrophy. And you can see that on an MRI scan or a CAT scan. And then specifically the parts of the brain that become affected early on are your language centers and your memory centers. And those parts of the brain really shrink up to almost nothing. And just to be totally technical, the hippocampus is a part of the brain that's affected, the parietal lobes, the temporal lobes, and ultimately the frontal lobes. So a typical person who has Alzheimer's, Henrietta. She's age 79, she's from Florida. She shows up on her younger sister's doorstep, who's only 75, in Kansas City with her new boyfriend, who's about 30 years old. Henrietta is intoxicated. She's got a black eye. She can't really explain what it is. She's just there because it was her boyfriend's idea. Her boyfriend wanted to go and meet her sister. And it turns out, after some investigation, Henrietta's trailer where she lived in Florida after her husband died was in total disarray. There were thousands of dollars that were missing from her bank account. And in hindsight, it looks like the boyfriend was thinking, oh, well, I'm going to go see Henrietta's sister and maybe I can get more money. But Henrietta's sister wasn't cognitively impaired and didn't have Alzheimer's. So this is a very classic case of somebody who probably needs a guardian, but is unaware that she really has a problem. And here's another picture. A PET scan or a SPECT scan are functional tests. They're coming into vogue a little bit to help us diagnose various brain diseases. And on this kind of a test, red is a good color, yellow's a pretty good color, blue, black, green, those are not good colors. And you can just see parts of the brain in people who have Alzheimer's, the cells are there, but they're just not doing anything. And that's what this kind of a scan shows you. A few words about frontotemporal dementia. So it has 3 different kind of clinical variants. The one that causes the most distress and can upend an entire assisted living facility, for example, is the behavioral variant. And there people are very impulsive. They are unaware of the impact of their actions and what they say and do on all the people around them. Other types of frontotemporal dementia affect language. So there's semantic dementia or primary progressive aphasia. People lose nouns. So as they talk, they stop using any nouns in their sentences. And I can't even emulate that. It's so hard to do if your brain is actually working well. And ultimately, people who have semantic dementia get to a point where they say lots of words, but none of it makes any sense. So the rest of us can't understand what they're saying. There's also what we call non-fluent progressive aphasia, all these complicated terms. And that's where a person's speech becomes telegraphic, and they lose all the connectors. So these particular kinds of dementia, because they affect the frontal lobes, and that's very important in executive functioning, these kind of dementias are very impairing as far as a person's ability to make decisions. Personality changes are particularly common. You can also see what we call apathetic behavior, or where a person's attention becomes turned inward and they just don't engage with the environment anymore. It can look a little bit like depression, but it's very different illness. It doesn't have sleep problems and appetite problems that go with it. It really has to do with a person's ability to initiate. They just have no interest or ability in initiating actions. And that's what apathy can look like. Versus the impulsive person who's always all over the map, doing things, saying things, sort of without rhyme or reason. Lewy body dementia, which, as I've mentioned, overlaps with Parkinson's. Visual hallucinations are the most common first symptom in over half of the people who have it. But not everybody who has Lewy body disease does have visual hallucinations. If they don't have visual hallucinations, they do develop paranoia or suspiciousness and fearfulness that people are trying to hurt them, or delusions, fixed false beliefs. Those are quite common. There's that waxing and waning. Insight changes related to how symptomatic a person is. So when a person is very psychotic, having hallucinations, paranoia, delusions, their insight is very impaired, but at other times their insight is actually fairly intact and they're very aware that they have a problem. As the illness progresses, people do get to a point in time where they have less and less insight. Like Alzheimer's disease, conversational speech can sound very normal. In fact, many people who have Alzheimer's disease have some Lewy bodies in their brain cells at autopsy. So there is some overlap between the two illnesses. A few words about executive functioning. I know I've talked about it a lot, and this will be a little bit of a repetition here, but you know, like any good teacher, repeat, repeat, repeat. This is an organized description of what executive functioning is, whereas the description that I gave earlier were a little bit less formal. So basically, executive functioning has to do with all these highfalutin things, the integrative, synthetic, generative functions. So the parts of your brain that put it all together, the parts of the brain that synthesize and help you make new insights, get new insights, and the part of your brain that helps you generate thoughts, actions, plans. And the other part of executive functioning is that after you have a plan and you're carrying it out, it's that part of your brain that helps you figure out if you're getting to where you want to go. Do I need a detour? Or should I just keep going the direction I'm going? It's very complicated. And it does depend on having lots of other parts of your brain working. You have to be able to use and understand language. You have to have intact memory. You have to be able to use tools. You have to be able to perceive the environment. So it's quite complicated. So this is about judging, choosing, initiating, and I really think I've probably gone through this whole thing earlier in the talk, but you can have the slides to refer back to. What does it look like when it's not working? So a person is not insightful about what the problem is that they need to design a solution for. They're concrete. They just take it one thing at a time. If it's not in front of me, it doesn't exist, it's not a problem. People have poor judgment. They make poor choices. And it's not they make poor choices because they want to make poor choices. They make poor choices because they can't make a choice. And that's sort of the difference in somebody who has capacity versus somebody who's, willful. A person's ability to plan when they're having executive dysfunction, their fluency, their retrieval of information is impaired. Their strategies, instead of taking the 3-step strategy when there's a traffic jam, they take a 25-step process to try and get around the traffic jam. People's ability to hold things in their head, called working memory, is impaired. In fact, not being able to figure out how to get dressed, which is a sequential motor task, that's a executive dysfunction, when people can't even pick out the things, match them up, more or less, depending on your taste, and then put it all together, execute the plan, get dressed, and go on with your day. You can have slowing of thoughts, slowing of actions, or in fact, being too rapid. And then monitoring what you're doing, monitoring the environment for how things are responding. That's really one of the key things in being a safe driver. You have to be able to take into account all sorts of different information about your car and whether it's getting overheated, does it have enough gas, information about the traffic in front of you, information about the road conditions, information about the weather, and then of course, where is it that you want to go? So there's lots of things that you have to monitor when you're doing a complex task. And then finally, you need to be able to adjust what you're doing when something changes. And a deficit in that ability to adjust is called perseveration. When people just get stuck, they can't talk about anything else. They can't work on anything but one problem. It's very complicated, involves lots of different things. Not everybody who has executive dysfunction has impairment in every single step, but if you have a big enough impairment in one step, it can derail everything, or if you have lots of impairments in various steps, that can be enough to really impair your ability to make decisions. And assessment of it, as you can probably tell, is pretty tricky and really takes an expert to do if you want to tease it all apart. But as a court visitor, you're not going to need to do all the teasing apart. What you really are going to need to do is take a look at the whole thing and sort of, can this person put the whole thing together so that they can make good decisions? They can be consistent in expressing what they want. They can understand things. So that's really, you just need to know, is the whole package working together, not necessarily which parts are not working. Lots of things can affect executive functioning and cause executive dysfunction. And so I've sort of listed out some of the most common causes here. And it's very common in Alzheimer's disease. Sometimes people lose sight of that, but more than 50% of people, in fact, in this one study, 64% of people who had Alzheimer's had impairments in their executive functioning. And this, combined with that inability to form a new memory, which I talked about earlier, which is the central deficit in Alzheimer's, this is why it's one of the most common causes of incapacity. A few words about anosognosia. People make fun of me a little bit. It's one of my favorite words in the entire world, anosognosia. It took me a long time to figure out how to pronounce it, and when I give talks, other people have challenges. I've talked a little bit about it, and I think when people think about dementia, they think about cognition, and they think about memory, but I would argue that behavior is very important for our quality of life, how we're behaving, how other people are reacting to our behaviors. And likewise, people focus a lot on executive functioning. You'll notice I focused a lot on it during this talk. But anosognosia, or having awareness, is at least, if not more important. Because if your executive functioning skills aren't working, but you know they're not working, and you know you need help, and you can ask for help, and then you can accept help when it's offered to get to where you need to go, then it's far less important that your executive functioning isn't working if you're in an environment where the help is available. Whereas if you don't know that there's anything wrong, you're not going to be so willing or happy that other people want to help you. So it's the lack of insight, the unawareness of deficits, a lack of appreciation of the significance of deficits, and usually this is caused by problems either in the right parietal lobe or the prefrontal cortex, if you want to get technical about it. And basically, it works out to almost 1/3, 1/3, 1/3. Roughly, with people who have Alzheimer's, about 25 to 30% of people who have Alzheimer's actually are aware that their brain isn't working. and often are pretty distressed about it because it's so many different parts of their brain aren't working. But that group of people almost always accepts the help that they need. The people who you might run into more often in a guardianship kind of situation is people who either have total unawareness of their deficits, like the lady who answered, "I don't know," to 20 questions and then said, "Oh no, my memory's fine." That's a total unawareness. And then there's what I call shallow awareness. Yeah, my memory's not good, but if you were 85, your memory wouldn't be good either. Well, that may or may not be true, but we're here to talk about you, and you are having problems, you've gotten these traffic tickets, your rent didn't get paid, all these things are happening to you. What do you think caused that? What's your explanation for that? And if they give an explanation that is totally unrelated or impossible to believe, that's where you would get to what I call shallow awareness. And that's very impairing as well. Oh, how'd I do on my stats? 38%, 38%, and 24%, pretty close. Frontotemporal lobe dementia or frontotemporal dementia, especially the behavioral variant, it is this anosognosia, this lack of appreciation for deficits that causes so many of the problems. It causes people to have behavioral problems. It causes mismatch between how a person is acting and the environment that they're in, and it makes it very hard to care for people. And so this is one of the key things that you will run into quite frequently as you work with guardianships if you're dealing with older adults who are having cognitive problems. How do you make a diagnosis? History, 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 some testing, some functional testing. Again, nobody's expecting you to make a diagnosis. Key things to keep in mind. Conversational speech is preserved long into the illness in Alzheimer's dementia as well as other types of dementia. So it's going to sound normal, the flow of your conversation with the person. If you don't have any other information about the person, you may walk away and think there's nothing wrong with them. That's why it's very important to be armed with the facts that you've gathered from other people when you're talking to someone and see, does this person have awareness of what's actually happening in their life, what their real challenges are. And so you need to have a special kind of conversation when you're assessing people for dementia. Just a word about older adults. One of the great and wonderful things about older adults is that they are all so much different than each other. We all sort of start out kind of the same, little babies, kids, relatively uncomplicated, comparatively speaking. And things, as you go through day by day, year by year, different things happen to you. You have different opportunities, different challenges. And so you become different and you change. And older adults have far more days and years that they've gone through. So the older you are, the more complicated you are, the more chance there is that all sorts of things have happened to you. And with older adults in particular, health problems, losses, and loss is a chronic part of getting older. You lose your job, you lose your family, you might lose where you're living. People are exposed to far more medicines because they have far more illnesses. And then finally, you get into those tough life and death kind of issues. Really, most of us should be a little bit aware of the fact that we're going to die. But the older you get, the more in touch people often are that they are going to die. When you're talking to people, vague speech, again, is a very key thing. And one of the hardest things to do, and even as a doctor, even as somebody whose job it is to really ferret it out and figure it all out, it can be challenging for me to do, but when there's an amazing capacity for other people to get you to fill in the blanks for them. They'll sort of pause, and it's our natural, socially appropriate thing to do when we see another person struggling is to try and help out. And as a court visitor, that is really contraindicated. You really want to avoid doing that. And if you happen to be interviewing them with their loved ones in the same room, you need them to not fill in the blanks. That's one of the reasons why people don't realize how impaired the person they're living with is. Because you've been married to someone for 30, 40, 50 years, you know each other, you know what each other mean, you know what's next, you know what to expect often. And so you actually aren't testing people. Well, why would you? I mean, it's your spouse, for example. But that filling in the blanks, that compensating for other people, especially when you have a dementia that changes slowly, day over day, month over month, it's almost imperceptible, the changes. And so you compensate, because the whole goal is everybody wants to continue to live well and do well. So you compensate for each other. That's what being married is all about, for instance. So you have to evaluate a person, converse with a person without any of the compensation when you're really evaluating this particular person. Because what if their spouse, who's been compensating for them, what if they have a terminal illness? What if they die? What if they get hit by a car? Then that person is going to be stuck there. And your job is to let the judge know as best you can how this person is able to do. So watching out for that. And if you find that you do fill in the blanks for someone while you're talking to them, that's okay. Just keep going and work on another question, but be conscious of it. So one example, an example that a judge could use, you got a courtroom, you got the two tables, you got people standing there, asking the person, who's the person standing next to you? Hopefully they'll say, my lawyer. And then what's the relationship? What happened? Why are we here? What are you expecting to have happen? What are the issues at stake? And if a person can't answer all those things, that's when you really have to start looking at, does this person have impairment? Changes in personality, new onset criminal behavior, angry denial or sincere profession that, oh, I have no memory. Other things, people use the same words. If a person repeats the same story in the same words over and over, that's when you know there's a problem. And finally, knowledge can become very context specific. Oh, I hear Joe helped you move. I don't know anybody named Joe. I don't have a friend named Joe. No one helped me move. I moved in by myself. Oh, I thought you had a daughter who was married to Joe. No. Oh, I thought you have a son-in-law named Joe. Oh, yeah. I've got a son-in-law named Joe. He helped me move. Classic conversation. But that's the kind of thing that is very disabling in a person's ability to make good decisions, even though it's not that ability to know who Joe is, per se, but it's the ability for your knowledge to apply to all the things it needs to apply to so that you can make good decisions. Avoid yes-no questions. Yes-no questions are the enemy. You really need people to talk in sentences and phrases. You need them to explain back what you explain to them. And you need to see, do they understand generally what you're asking? And then do they understand that it applies to them in their specific situation? And then are they consistent? And do they have an explanation that makes sense for what it is they're saying, for the choices that they're making? Just a side note, if people are having delusions, fixed false beliefs, people are following me, or my neighbor is watching me all the time, or somebody implanted cameras in my head, if somebody has delusions, paranoia, or that perseveration where they can't move on from a topic, all of that indicates that they probably have a moderate or more level of impairment. Levels of impairment in understanding really reflects lots of different losses. So once you get to that point, there's lots of things that aren't working well. Common errors when you talk to people, being misled by that conversational speech, not taking into account the loss of functioning compared to their previous level. So if you have an engineer, somebody who did mechanical drawings, or an architect who did drawings of things, if they can still do a simple drawing, well, that's great, but that's not very helpful. The question is, can they still do what they used to do? Somebody with advanced dementia, a doctor I know, he could go in and give wound care orders for everybody in the nursing home, because that's what he did for 30, 40, 50 years. But that actually doesn't mean that he could make good decisions for himself. So if he can still give you wound care orders, that's great, but he's probably not going to be up on the most recent techniques and the most recent supplies one needs. And you need to verify what people tell you. You can't take it on face value, because people will inadvertently, not on purpose, mislead you because their brain is broken. So this has been an overview, hopefully helpful, of the things that I think a court visitor needs to know when they're talking to older adults, and especially a big focus on people who have dementia, cognitive impairment, people who have delirium. It's a big job you have, it's really important, and ultimately, you want to know the big picture. Thank you so much for your attention, and it's been great talking.